Good morning, all of you. Myself, Dr. Garima. I am fellow in neonatology, and I'm going to present today's case under esteemed guidance of our HOD Professor Girish Gupta sir and Assistant Professor Dr. Sekit Patra. We have a newborn who delivered with these kind of lesions. They are scattered, they are dry, superficial erosions. They are scattered all over the body, involving trunk and extremities, with a turbid fluid-filled bulla present over the right hand with an erythematous base, and there are multiple ruptured and unruptured vesicles present over the left foot with basal erythema, and mucosa and eye was spared in this baby. So this baby born to a mother who was 30-year-old with blood group B positive. She was gravided to para to live 1. Previous sibling was delivered at preterm at 7 months of gestation. This present pregnancy was spontaneous conception and she was booked outside. She was regular iron and folic acid supplementation. Total number of scans done were 3. All scans, they were suggestive of a non-obstructive communicating hydrocephalus with polyhydramnios, though we could not have AFI available in that. There was no overt history of a rash in mother, and she did not have any fever, any gingivostomatitis, in joint pain, discharge, bleeding PV, or any exposure to COVID. Her viral marker status HIV, HBs, HCV was negative, and VDRL was non-reactive, but complete torch profile of the mother was not available to us. Mother also had leaking PV and pain abdomen for 1 day, for which she received appropriate antibiotics, delivered vaginally at 29 weeks plus 2 days of gestation. Baby did not cry after birth and received positive pressure ventilation with TP's resuscitator, followed by intubation. Apgar score expanded was 2, 3, 5, and 7. She has been covered with full dose of steroids and received 1 dose of magnesium sulfate for neuroprotection. Placental details I'll be sharing. Expanded Apgar score, apart from that normal score, whatever the additional modality that we are giving, we should document that. Like at 1 minute, baby received PPV. So this is expanded Apgar score. The gross examination of placenta was normal, and placenta has been sent for histopathological examination. So this baby is 29 weeks plus 2 days with weight of 1260 gram weight, very low birth weight, appropriate for gestation age, with perinatal asphyxia, with multi-organ dysfunction, with RDS, with seizures and meningoencephalitis, with coagulopathy, with vesiculobullous rash with erosive lesions, with communicating hydrocephalus, with septic shock. So we kept differential of intrauterine infections, staph scalded skin syndrome, congenital syphilis, and disseminated fungal infection. Post-resuscitation examination of the baby was showing that temperature was 36.5, color was pink, mild tachypnea, rate of 68, and saturation of 92% on FiO2 of 60%. Perfusion was fair as CFT less than 2 seconds, mean blood pressure was 32 mmHg, PI was 0.8, and sugars were normal. Baby was very low birth weight and head circumference was appropriate at 50th centile. On head-to-toe examination, anterior fontanelle was open at level. Baby was encephalopathic altered sensorium. No facial dysmorphism was present, and the skin lesions that I have described, that exfoliative lesions were present all over the body with blisters present over the hand and feet. And mucosa in eye, oral, and anal were spared. Respiratory, there was tachypnea, retractions with grunting, with bilateral ear entry was equal with score of 5/10. Breast systemic examination was normal and there was no hepatosplenomegaly. So on this clinical background of clinical picture we had and details we had, we made a differential diagnosis for skin lesions that was generalized exfoliative lesions with vesiculobullous rash. Could be because of infective etiology, that could be congenital vesiculopustular lesions like epidermolysis bullosa, or it could be benign vesiculopustular eruptions, though this entity usually does not present at birth time. So among the infective, that was our high possibility. There can be bacterial cause due to Staph aureus, Listeria monocytogenes, Streptococcus, Pseudomonas, or Treponema pallidum. Among the viral, herpes groupovirus, cytomegalovirus, Coxsackie, and COVID, and fungal can be because of candidiasis. So we planned out our workup and we immediately sent that blue still fluid for stain, KOH, culture sensitivity, and Zang smear. In view of bacterial organism, we sent septic screen and VDRL for treponema. For the viral CMV, PCR, and COVID testing, and complete urine analysis, including the fungal hyphae. Another workup in view of antenatal hydrocephalus, neuroimaging has been planned. EG and VEP, ophthalmological evaluation to rule out any evidence of intrauterine infection or chorioretinitis, better, and if needed, skin biopsy. So empirically, in view of suspected sepsis, we started IV antibiotics, augmentin and amikacin. Since there is cutaneous and neurological involvement and among treatable cause of virus, there was herpes, so we started IV acyclovir. And this kind of rash can present in fungal cases also at birth, involving hand and foot, so we started fluconazole. Now I'll be discussing various issues of this baby. Baby had perinatal asphyxia with multi-organ dysfunction. We had a first-star EBG available with us, which is suggestive of respiratory acidosis with metabolic acidosis. Baby had respiratory distress in view of preterm. There was increased retractions and baby had high FiO2 requirement. We did not have X-ray available immediately, so we did focus thorax, which was suggestive of these thickened pleural lines hyperechoic with confluent B lines. So we gave surfactant. Post-surfactant, X-ray was showing good expansion with some visible air bronchograms. Then baby developed shock within 24 hours of life that worsened at day 7 of life. Clinically, baby started having tachycardia with perfusion was getting impaired, but mean blood pressure maintained to 32 mmHg. Peripheries were cold, was in altered sensorium. EBG was suggestive of raised lactate. IVC was showing less collapsible, and 2D echo done to document good myocardial contractility. And in view of perinatal asphyxia, there could be evidence of cardiomyopathy, which has been ruled out as the cardiac enzymes, they were normal and ECG was also normal with no evidence of PD and PPHN. Giving antibiotics, we titrated ionotropes according to the shock, started dobutamine, then adrenaline and dopamine. Baby had encephalopathy as depressed sensorium was there, pupils were sluggish, reacting to light, and withdrawal reflex was present. This baby was not a candidate for therapeutic hypothermia, and CFM monitoring could not be done in this baby as it has been engaged in our department for another baby. Baby had seizures at 6 hours of life. That was multifocal clonic seizure, for which metabolic causes ruled out, and phenobarbital loading with 20 milligram per kg was done. Then second episode at 60 hours, for which second loading with phenobarbital was done. Third episode at 76 hours of life, for which phenytoin loading with 20 milligram per kg followed by maintenance started. And fourth episode at day 7, that was myoclonic type, third time loading with levetiracetam was done. So there was normoglycemia and normal calcium. This seizure is attributed to hypoxic encephalopathy. Its onset is within 24 hours, but since it persisted till day 7, so we suspected there could be ongoing meningoencephalitis, though we have done CSF soon after birth, which was suggestive xanthochromic. Cells were raised 380 cells and predominantly mononuclear cells. It was non-traumatic hemorrhagic CSF showing RBCs 10 to 15 with low sugar and raised protein, and culture was sterile, going in favor of viral meningoencephalitis. So we sent one sample for HSV PCR analysis. Ultrasound was showing dilation of ventricles, which has been documented, and ventricular index was significantly high, more on the left side, and there was dilation of all 4 ventricles. So Levin's index was showing at 29 weeks of gestation, more than 97 plus 4th centile, so significant hydrocephalus was there. Then we did lab parameters of this baby, and counts at the time of birth were very high, like 44,000, and gradually it was showing decreasing trend to 48,000 at day 7 of life. Platelet counts, they were maintained. By day 7, they dropped to 1 lakh. And absolute neutrophil count was also showing decreasing trend by day 7. CRP was showing rising trend. At birth, it was less than 0.5. Then it was raised up to 18, then 41 milligram per year. In view of multi-organ dysfunction, we monitored for LFT, which was normal, and renal function parameters were also monitored. And baby had a deranged coagulation profile, though no clinical bleeding was there, but we transfused with FFP. So we got the reports of our workup that has been sent. So COVID report was negative. Blood culture was sterile, that has been repeated twice. Blister fluid analysis was showing that culture was sterile, and KOH mount was not showing any fungal element. And urine analysis was also normal with no fungal evidence. Here we try to extract history from parents again. And surprisingly, we got that mother had a history of a genital rash that was white in color, though painless, but associated with itching and some discharge, and that resolved with some local applicant, and it remained for around 5 days in second trimester of pregnancy. And then we got a history from father also, that during second month of gestation, father also had some swelling over penile skin, He mentioned that it was some kind of an ulcerative lesion was present, for which he took some treatment for 1 month duration. But unfortunately, we could not get details of medication that he has received. So we tried to trace maternal torch profile. So now on this clinical background of cutaneous erosions with blisters, with meningoencephalitis, with parents' history of genital rash, we had a differential diagnosis. It could be because of Staphylococcus scalded skin syndrome, as point in favor was exfoliation was present with basal erythema, mucosa was spared, and pus culture was sterile. Because this entity is toxin mediated, not organism mediated, so we can get pus culture sterile. But it rarely present at birth, and we get usually blisters at mechanical site of stress like buttocks and all. And here it was no crusting is there. Classically, we get some crusting in the perioral area or some diffuse erythema or beast formation, which was not in our case. Second differential was congenital herpes. As point in favor was vesicular eruption were present at birth. There was meningoencephalitis, and history of genital lesions in parents was present at different months of gestation. But at the onset, we did not have any overt history of a rash, and no genital lesion was present before delivery. Usually, how does herpes simplex present? It have a cluster type of a vesicular rash, and along with that, there can be erosions associated with this. Then third differential we kept for neonatal sepsis, as there was pustule was present on erythematous base with evidence of CSF, infected CSF, and risk factor like leaking PV was present in mother, baby had high counts, and rising CRP trend was there. But blood culture was sterile. Syphilis, though rare entity, but can be considered in this patient as evidence of blister is there with meningoencephalitis, and genital lesion in parents was present. Apparently, it was looking that there is involvement of hand and foot. But in syphilis, you usually get lesions affecting palms and soles. Our baby was having hand and foot involvement, and mother VDRL was non-reactive. So these kind of lesions that we get in syphilis, they are usually large bullas, and we may get pigmented lesions over palms and soles. Varicella zoster ruled out, as mother did not have any history of fever or rash prior to or after delivery. Congenital CMV could be considered as in view of hydrocephalus with vesicular eruption, but our baby was appropriate for gestation age, and there is no evidence of microcephaly, no petechiae, or no organomegaly. COVID-MISN could be considered as baby was preterm with multi-system involvement was there, but mother did not have any history of contact, and we got COVID negative. Congenital candidiasis can have onset at birth with multi-system involvement, but we did not isolate any fungal element from any site, and there was no involvement of palms and soles. How does congenital cutaneous candidiasis present? This can have a diffuse maculopapular rash. They can be dry, flaky rash, and classically we can get on the umbilical cord. You can see these yellow-white plaques on the umbilical cord. Another entity that we kept as in differential was congenital epidermolysis bullosa, as it can have presentation at birth, and there can be raw erosions or ruptured bulli. But usually they are very fragile at areas of pressure associated with atrophic scarring or nail involvement, which was not in our case. So we got detailed workup of our patient, and we got all tests negative for syphilis. Zank smear was showing no acantholytic cells. Urine CMV PCR was negative. And in the TORCH serology, we got IgM positive for HSV2 as well as for IgG was positive. And we able to isolate HSV2 DNA from CSF also. Fundus was normal. And our diagnosis has been supported by the maternal TORCH profile, and she was also tested positive for HSV2, both IgM and IgG. So we tried to trace our histopathology of our placenta. It was quite non-specific in this case. It was suggestive of focal dystrophic calcification, but we should keep in mind that placenta can helpful in diagnosis of such kind of a presentation, where you may get some necrotizing inflammation or immunohistochemistry. You can isolate HSV2 in amniocytes. We could not get EEG done in our case, but it is suggestive of, it helps in diagnosis as well as in prognostication of HSV encephalitis, where you may get some diffuse slow background with sharp and slow waves, and or you may get some isoelectric pattern also, which is suggestive of poor prognosis. So we treated our patient with IV acyclovir with dose of 20 milligram per kg per dose 3 times a day with functioning of renal function monitoring and blood pressure monitoring. As our case was CNS or disseminated disease, so duration we planned for 21 days, and repeat LP was also planned near the end of therapy. IV should always be followed by oral acyclovir for 6 months. We gave supportive care in form of local application of mupirocin and some emollients after dermatology consultation, though we could have considered topical acyclovir application in this case, which we have not done. Measures have been taken to prevent insensible loss, and developmentally supportive care continued. So this baby, course of that baby received a post-resuscitation surfactant, was on mechanical ventilation, empirical antimicrobials were started, augmentin, amikacin, acyclovir, fluconazole, TPN was started on day 1 and buccal application of colostrum was done. Baby was re-extubated on day 3 to NIV mode, and feeds were started by day 2, continuation of partial parenteral nutrition. Then baby had desaturation, so re-intubated. Following day, there was increased secretions, CRP was high, metabolic acidosis was there with raised lactate. So we upgraded antibiotic to piperacillin and vancomycin. Then by day 7 of life, baby went into septic shock. There was sclerema present, abdominal distension was there. So we kept baby NPO. We upgraded our antibiotics. We gave IVIG, central catheters removed, inotropes titrated. We gave steroid for refractory shock. We could have considered DVT in these cases as there was a sclerema was there, but we have not done again in this case. By day 8, baby had bradycardia with desaturation and myoclonic jerks, and baby expired at day 8 of life. All throughout the course, baby did not have any new skin or mucosal lesions. In fact, the lesion present at birth were in the healing phase. So this paper is showing that HSV can have varied kind of cutaneous manifestations, which can be very non-specific sometimes. So clinicians should keep low threshold for HSV testing, especially in preterms with atypical cutaneous lesions. So I will conclude my presentation that for diagnosing HSV encephalitis, we should keep high index of suspicion. Any newborn who is presenting with non-specific symptoms like fever, poor feeding, lethargy, or seizure, suspect HSV. Many times we cannot get history of any active infection in mother or primary or secondary, but any vesicular rash in an infant up to 8 weeks should be cultured, and we can give some treatable causes like antiviral therapy with acyclovir pending culture results should be started. Culture should be sent for all sites like blood, CSF, urine, or fluid from eye, nose, and mucous membrane, and CSF should be tested for HSV by PCR assay. So take-home message for this case today was that every mother should be screened for torch infections. Like in our case, we did not have torch available at the time of delivery. Any rash in the mother should not be ignored, and its potential consequence in fetus should be kept in mind. Many of the infections, they can be because of asymptomatic cervical shedding after a primary episode of genital HSV in 3rd trimester. All primary episodes of HSV in mother or secondary episode should be treated with antiviral therapy. Whenever mother is having some symptomatic or asymptomatic primary genital HSV, that there can be preterm labor and low birth weight infant, like in our case. Treatable causes of infection should be kept in mind. And most important, prevention of secondary infection should always be our priority. Thank you very much for your patience listening.